If you enjoy this content, please take a moment to rate and review it. Your feedback will greatly impact our ability to reach more people. Thank you. Emily, how's it going?
Oh, Marcus, it's going well.
Good.
Going well.
Good. Thank you for sitting in. Vic is, I said Fiji to you earlier, but he's in Peru. A much better place
You're
to be.
off by half a hemisphere.
Yeah,
It's okay.
basically. Yeah, but not by the number of letters or syllables.
No,
I was dead on with letters and syllables. Just, the whole geography thing is a different it's a different matter.
Yeah.
Oh man. Anyway, listen, two things. One, I am here and I hit record and I got everything together and I talked to Aaron, so we will have a show this week.
Okay.
But that's about it. Okay. I had no time to prep for anything, but that's okay because there's only really one thing I want to talk about this week.
Okay.
I did skim the AI news. Last week was a big one with Google I/O,
Yeah.
and OpenAI bought John AI for $6 billion. This week, not so exciting, quite frankly.
Yeah.
So I don't feel like we need to track a bunch of stuff. NVIDIA did have a good week.
Yeah.
So that was,
Yeah, and I do want to talk a little bit about the controversy around AI.
Okay.
This idea that it's going to, raise unemployment 20% or it's going to destroy the workforce. There's never been an
okay. Let's make sure we cover your stuff
right,
first, and then we'll talk about this.
Okay, all right.
And then we'll talk about this
because I'm interested in. Well, first of all, it's the second time I've heard it in my lifetime, so that's why I'm particularly interested.
Okay. All right. Well, I can go there. I'm a technologist. So this is what I want to talk about. Okay. All right. But honestly, the thing that caught my eye when I wasn't, just trying to pull myself out of the quicksand that was my to-dos this week, sort of two things, and they were both DC related. HFMA put out an article talking about what some of the actual impacts are going to be from the reconciliation bill, big beautiful bill, whatever you call this thing.
Yeah, one big beautiful bill.
Okay, that's the brand. That's the brand.
Well, that's the brand, and you have to have the hand motion.
Yeah.
If you're listening to this, you can't see. It's like you get the feeling he's talking about something other than a bill
because he's got a shape to it. Is there a shape to this bill? Oh my God.
Kind of like an hourglass.
Yes. So I want to talk about that because it's been out there a while, and I think the analysts have started to pick it apart a bit, and you are one of those good analysts. And then the other thing was, kind of hot off the presses today is the court's decision around the tariffs and now sort of all of that stuff. So anyway, I just got done with a call. It was either earlier this week or last week with our portfolio. I do those quarterly calls when I run through trends, and I honestly was pretty pissed at the end of the call because quarter after quarter, for what feels like 2 years now, kind of when all the Fed funds rate stuff really got nasty, and I've just had nothing but bad news for the portfolio for two straight years in these quarterly calls, and this one was even worse because not only was it bad news, but there was nothing definitive I could tell them because at that point I don't think there was a ton of clarity yet. So I'm excited to have you here to talk us through what you have found and for me to ask you some questions about it.
Okay. All right. Well, so why don't I just offer up some of the key federal policy categories, for lack of a better word.
Okay.
And if you could go there, for people who are watching this visually, you can see a list here, which is, the first definitive policy we've gotten out of Secretary of Health and Human Services Robert F. Kennedy is this Make America Healthy Again Commission report, which came out late last week. Okay. The second piece of it is the One Big Beautiful Bill that we were discussing, which is moving through Congress. And then the third piece of it, which is still, ephemeral, is the deregulation piece. Okay. And those are right now the three major legs of the health policy stool. Okay. This will evolve over time. The One Big Beautiful Bill will become something else. Make America Healthy Again is template and a roadmap. So
it's an initiative, right?
It's an initiative, and it sets the tone and the direction that the Secretary of Health and Human Services wants to take for healthy. And it is an important report because if you think about how, going back to the Affordable Care Act, how that was framed up in particular, less so when you look at Medicare and Medicaid and even going back to Social Security with Franklin Delano Roosevelt's presidency. But if you look really at the Affordable Care Act, and particularly that period, I don't know, around 2006, 7 on, the premise of the federal government is you are either sick or you will be sick.
Yeah.
And we need to make sure we have all the resources in place for that to happen. That, of course, created a lot of supply, right? Because you've got so much money pouring into the system. And of course, in healthcare, it's one of the few places where this happens, where that supply can drive demand, because it's so technical in nature. People defer to their doctors, and those kinds of things.
Let me make sure that I understand what you mean when you say driving supply. So I think what you're saying is the supply at the core is enrolled patients.
The supply
enrolled members.
The supply is hospitals, physicians, outpatient centers, labs, what have you.
Okay.
That's the supply.
Okay.
That supply is funded 55% by the federal government.
Right.
Okay. And that supply needs demand.
Okay.
Unlike many industries, it can actually create demand. If, for example, you go into the doctor and your knee hurts.
Got it.
Okay.
Got it.
Before you know it, you're getting your knee replaced in between here and there.
Yep. Okay. Tracking.
That's what
tracking. Okay. Because our industry is weird, where it's like a triangle, right? So you could have meant the supply was, as we grow the number of enrolled members, that grows the P&L for the payers, which then grows more throughput for. So I just didn't know which direction you were talking about, but I see
supply.
What you're saying.
The supply can induce demand.
Yeah. Okay.
And sometimes.
Okay.
Nobody's happy about that, but that it can do that.
Yeah.
So this is a seismic shift when you say everybody is sick, or everybody's going to be sick, and therefore we need to have insurance coverage, and we need to have the
that was the core premise of the Affordable Care Act.
Really
was everybody needs to have coverage.
Right.
Yes.
Right.
Okay.
And we're shifting that to your default proposition. The default proposition for all Americans is that you're healthy. And we're going to guide you towards the things you need to do to stay healthy.
Yeah.
Because if that thing that goes wrong at 50 doesn't go wrong until 60, and that thing that heart disease or diabetes or whatever doesn't happen until 70, well, you've changed the whole trajectory of your health. And not just dying and not dying, not the binary part, but the quality of life part. That's important. And in so doing, saying, all right, America, we believe you are first and foremost healthy. We've got the systems in place if you're not, but we believe you are healthy. You should be healthy. Policy should support good health. And that's how we are going to reduce the cost of healthcare expenditures in this country.
Okay.
All right. We're not going to cover everybody with insurance. We're going to make them healthy. And that's why it's Make America Healthy Again.
Okay.
And this, by the way, was the premise of...
I have to say, Make America Healthy Again is actually a clearer proposition than Make America Great Again.
Oh, I know.
Which is so much more subjective and to who and what and by what measures. Yeah. Whereas, health, we actually have you may not like them, but we have the World Health Organization. We've got some things we could point to, and we could say this is what good health looks like, the Commonwealth Fund, et cetera. So anyway, I just want to make the point that this is actually
and it is culturally a big change.
It's a massive change
to say all the children in this country should be healthy. They should not be obese. They should not have asthma. They should not have food allergies. They should not have this cancer spike. They shouldn't. None of these things should be the case.
Yeah.
So what do we do to fix that? That's a different thing.
Yeah.
And that's a different way of thinking. So it's a very important change, and it has created these really weird political dynamics where you find Robert F. Kennedy testifying before the Senate Health Committee, and he's doing battle with Patty Murray, senator from Washington.
Okay.
And and she's asking him a question, and he says, "Where have you been? You've been up here for, I think it's 32 years. Mm-hmm. What have you done?"
Yeah, no, listen, I mean, I have to say, for any of the critiques of Robert F. Kennedy, and I think there are some fair ones.
Yeah,
I think there are plenty fair ones.
Yeah.
You know, the consistent problem at the core of things like trying to challenge Make America Healthy Again is this has been the dirty secret that, I mean, I've only been in the healthcare industry for a decade, right? But a decade is long enough to know that this is
the right decade.
Yeah, kind of, right? And long enough to know that this was the thing that kind of everyone said needed to happen, wasn't going to happen. Mm-hmm. And in the absence of it happening, in the 10 years I was in it, I watched the spending double from 2 to 4 trillion, right?
Yeah.
And also, in parallel, we had the rise of the longevity, the Peter Attias, the Andrew Hubermans, and, you know, wealthy people are already doing Make America Healthy Again.
Right. So it always starts at the top.
Yeah. The wealthy people are already doing it, right? You know, and so this is really it's really a massive disruption. This is a true disruption.
It really is. And one of the weird political dynamics here is that you find people who you would think of as progressives, liberals, defending the status quo.
Well, because the disruption has consequences to get to the other side. And so it's really about who was going to have the political will to carry the disruption out.
Right. And who thought it was going to be Donald Trump?
No. Well, it really wasn't Donald Trump.
Well,
it's really Robert F. Kennedy.
Yeah.
It's Robert F. Kennedy, and he played a very good game of political chess and put himself in the position to execute what he wanted. Yeah, I would call it brilliant. I would agree with that.
So the second part, one big beautiful bill, that's legislative. So
is there anything else we need to talk about on the Make America Healthy Again piece?
No, I want to show you a few slides here, a few pictures, because I think the Make America Healthy Again, if you think of it as a top-down mandate, you're thinking about it wrong. And if you go and you look at this next slide right here.
Do you want me to?
Yeah, just advance that. And you can see this is the year over year. If you're just listening to this, the slide shows year over year historical and projected enrollment in Medicare. And what you see on this chart is that the American healthcare system was built for that period from, say, 1978 to 2012, where the post-war population really was the preoccupation of the healthcare system. And it's no accident the Affordable Care Act was passed in 2010, where that big bolus of post-war population was getting into their sick years, their cancer years, you know, and needing some answer, especially for the self-employed population. The healthcare system was not built for what's coming next, which is a very sharp year-over-year decline in the over 65 population.
Yes, so the demography shift.
Yeah. So that demography is going to be wanting different things than the population that was born right after World War II.
Yep. Okay.
And
fair.
so Make America Healthy Again is a timely message, and probably not coincidentally, because we are moving past how the post-war generation defined healthcare and towards something different. I'm not sure what that is. Something different.
I mean, nobody's sure what it is, but everyone also can look at the costs and the outcomes. And, you know, I mean, this is hard, right? But like to say year over year that Commonwealth Fund report like doesn't require some type of drastic action. Okay. Yeah. Well, I mean, you're kind of talking about running the country into the ground, right? Because that's, you know, the fundamental resource is the people.
Right.
And if you take that and you drag it over the course of 30 years, it means other countries are going to advance beyond the United States.
Right.
Like if these other countries pay less and have better outcomes, in another generation, if nothing changes there, these other countries will advance past us.
And that's timely. If you go to that next slide, this is the birth rates. All right. This slide shows the general fertility rate in the U.S. and then the crude birth rate per 1,000 women. And what you see is since 2007, and I'm going to mention 2006, 7 a lot. I don't know what happened in 2007 other than the launch of the iPhone, but whatever it was, it wasn't good for.
2007 was the launch of the iPhone. That's for sure. That's for sure.
So if you look at this birth rates, they really start hitting the skids on a multi-decade basis in 2007. So you don't have a population coming in to backfill that decline in the over 65 population is the most important point of that.
Do we want to go back to Big Beautiful Bill, or because I don't want to steal your thunder and drive you?
Let's focus on Make America Healthy again. And we'll circle back
to sounds good.
To that. And I want to say that one of the, in thinking about Make America Healthy Again, I think one of the surprise inflection points, or this inflection point that nobody expected, because everybody is in pharma, big biopharma, everybody's sort of expecting it to behave the way it's always expected, which is you get a drug approved, you shove it through the reimbursement system, through the marketing system, and voila, you have a blockbuster drug.
Yeah.
Okay. GLP-1 drugs, if you go to that slide right there.
Yeah.
GLP-1 drugs, great drug. Does all sorts of wonderful things, okay? At $1,000 at least a month. You know, it breaks the bank. And this is a slide that shows some of the Senate Help Committee's estimates of this.
But the prices have come down pretty quickly. Right. I mean, relative to other blockbuster drugs. I'm trying to think what else has come down this fast.
No, well, and you've got a lot of compounding going on, putting a lot of pressure on.
No, but that stopped, right? I mean, you got Hims and Hers partnering with Novo now because they can't really do the compounding, right? I mean,
right. Well, and they weren't getting the most important thing, which is they thought they would be able to get Medicare reimbursement.
Yeah.
And Medicare, they said, well, no. We're not doing that. And then they were like, well, we'll prescribe this to the American Academy of Pediatrics. Like, we'll prescribe this to children, 12 and up. And all of a sudden, you hear the Robert F. Kennedys and people who care about health going, no, wait a minute. This is obesity, okay? This is, if you're not in the camp of, well, everybody should learn to control themselves and eat right and take good care of themselves. You're not in that camp.
Yeah, which is very, very difficult given the environmental factors that we've built up in America today, right? I mean, I've been talking to people because I spent a week in Mexico City, and it's just, you can't ignore it. Like, everything's walkable. And I get back to Nashville, and it's like, I have to drive everywhere. I have to drive everywhere, and guess what? It's just that daily decrease of cardio activity, right?
Right. And if you're, and the food that we eat and the
and on and
water
on and on and on.
And this is the point of Make America Healthy Again. And he actually calls out in the Make America Healthy Again report the use of these anti-obesity medicines, because the trade-off is that your food supply is not great. You're not getting enough exercise, too much screen time, all of those things. All right. And what's the solution? Not more exercise, more sunshine, better food, a drug. And that represents, I think, an inflection point. People look back at it and go, "Oh, that was probably a big mistake."
Yeah.
From the
but it has become much more. Look, I'm someone who identifies as an athlete, and I recognize that there are a million things about that I am blessed to have, right? But I also know that it is not, and I'm somebody who still pays attention to this. It's not really politically correct from my position as an athlete to tell somebody else who may be, struggling, hey, why don't you do X, Y, Z, right? You know what I mean? Even though I know what it took for me to sort of get to this body composition, and and it was certainly resources. My socioeconomics absolutely play a meaningful role, and there's no question. But there's also a lot of hard work that went into that as well. It's not, it is not, and has not been politically correct to push that as a solution.
Right.
It is far more politically correct to push a drug as a solution. That's just sort of the way our society has sort of evolved.
And in the case of the GLP-1 anti-obesity medications, the proposal right before the Biden administration left office was, well, having obesity, not obesity, the noun, but obesity, the condition, having obesity is a chronic condition, and therefore under the chronic condition coverage rules, Medicare should cover it. Now, that rule has been revoked, but just compare that to a a policy that says, no, 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 no. What we need to do is educate people on the importance of sunshine, fresh air, exercise, and good food.
Yeah.
And it's basically, I was joking with somebody. I was like, yeah, it's just like your mom. Like, go outside and play.
Yeah.
Go get some sunshine.
Yeah. But we're a long way from that, right?
But we drifted.
We're a long way from that now.
Drifted away from that because why? Because our philosophy became, you are sick or you're going to be sick. And therefore, we need to have all of these resources available to you. Not you are healthy and you will continue to be healthy as long as you are educated, and we support that with our management of the food supply chain, with our attitude towards drugs, as a federal government. So just click on some of the key points from the Make America Healthy Again report. Are number one, bad food. 70% of children's calories come from ultra-processed foods. Right. Many of those in the school lunch program.
Sure.
And many are actually designed the way because of the advances in genomics and in chemistry. You can actually concoct a food item, an ultra-processed food item that limits the normal mechanisms in your brain.
Sure.
I said, okay, that's good.
Sure.
My husband buys these rolls at Trader Joe's. Okay, I have one of those. I think about it for the next 36 hours. I'm like, oh, I got to get another one of those. And then I'm like, wait a minute, it was just a roll.
Right.
50% of the diet of pregnant and postpartum women are ultra-processed foods, which is not great for baby nutrition. Then another point they make in the report is the environmental chemicals. The risk assessment that's done for environmental chemicals is conducted by the EPA. And it has minimums or maximums, I should say. And there's not really been enough research done on the cumulative effect of those things. And then their finding is unacceptably high rates of chemicals in the blood and urine of children and pregnant women. And then the last piece of it, which is really relevant to what we're talking about, is the overmedicalization of children in particular. And as kids get chronically ill because of bad food, not enough exercise, too much screen time, all right, the health system, this big giant supply, right, responds with increased prescription rates for ADHD, antidepressants, both of which we're not even sure they work that great.
Right.
Antipsychotics, not sure they work that way, and overprescription of antibiotics, which can be disastrous. And that's what I said the GLP-1 drug kind of represents an inflection point. And they go on in the report. If you go to the next one, here's some of the stats they give you: prevalence of pre-diabetic children aged 12 to 19. Now this chart goes back to 1999. If you took that chart back to 1975, it would be near zero.
But honestly, you don't have to.
You probably don't.
No, I'm just saying, like, this is crazy. So for those who are listening, from 1999 to 2002, it was in the, let's call it 12% range.
Call it 12.
We'll be generous. We'll call it 12%. And basically, you just go across, and now from 2015 to 2018. It's in the 28%. It's in the 28%. So it's more than doubled over the course of the last last 2 years, last 20 years, sorry.
With that little inflection point in that 2003, 2006 period. It's like, okay, what's going on there? And if you look at the next slide, cancer rates, this is in the, you could see an inflection point there. About 2005, this is cancer rates per 100,000, 0 to 1975 to 2022. And you see a real bump up there around 2006, 2007, for both cohorts, male and female, and which is, unheard of. Childhood cancers, which leukemia, for example, is one that St. Jude has done just crazy good work on that. But childhood cancers are pretty rare. Children are by definition healthy, for the most part.
Yeah, for the most part. Yeah, no, it's always surprising and dreadfully sad when a child gets cancer.
Right. Okay. So there's another. I think there's one more nice little data. Oh, this one you're gonna like. This one, Marcus. Okay.
I've seen this. Actually, I think Vic and I went through this one last week.
Did you?
Yeah,
okay.
No, we went through this one.
This is a rerun, and I want to give you some interesting historical facts. So when Harry Truman proposed a universal health insurance program in 1945.
Yep.
Okay. One of the statistics he cited was military readiness.
Mm-hmm.
Now, you can imagine if you're president and it's 1945,
Sure.
you're super interested in military readiness,
Yeah.
right?
Yeah.
Okay. 50% of the country, and it would have been just men at that time, would not meet the requirements for admission to enrolling in military services. Today, it's 77%.
Yeah.
Would not meet the requirements.
Nothing about this surprises me.
Yeah, and that's an increase of 6% since 2000.
Nothing about this surprises me. I grew up in America, and I also raised two boys in America.
Right.
And they are basically Gen Zs.
Right.
26, 24. And what I told Vic when we were going through this, because I've got a son in the military, is that he was not ready like right before he went in. But they have a program where they sort of like they kind of get you tuned up.
Right.
They kind of get you tuned up before you actually head to boot, because you can't off the street do boot. Like
right.
Most people cannot off the street do boot. Now, having said that, why do they have to have that primer prep before you get into boot is the question. And
right.
Did they always have to have that? And I just believe that when I was growing up, there was just a much more fundamental focus on physical fitness. Like it was part of the deal, certainly.
Oh yeah.
Certainly.
Yeah, we went, and this particularly showed up in that period 2007, 8, 9, 10. Like we ended, I think in 2012, the presidential fitness test and went to this kind of band, like almost I say, green, yellow, red in terms of fitness instead of passing, not passing. And of course, the point was to destigmatize. Yeah. And you just pointed out the obesity thing, destigmatizing. But, where's the point where your empathy, right, becomes actually, socially destructive.
Yeah.
And so, and that's, I think, where the MAHA committee is.
Well, look, I mean, think about it on an individual level, right? Does an individual make change by giving themselves unending grace, or by saying enough is enough? Shit, get your ass up and go do the walk, or drink the water, or put the damn soda down, or whatever. Like really though. Like what is it for an individual that actually drives them to change?
Right.
And then you think about that at the scale of a nation, right? And how those two things. I mean, it's one of the things that has been hard for me, because I'm StrengthsFinder says I'm not a very empathetic person. And so no, but this has actually been kind of a hard thing for me over the course of the last 25 years, because as you know, like I don't have any credentials, college dropout, sort of all the things. But we have at least up until now, lived in a society where your effort and being in the right place, can really help. You can overcome a lot. You can overcome a whole lot, right? You can overcome a lot. And when I look at a lot of people who, are struggling for one reason or another, and, to be honest, I don't spend a lot of time with those people, because, as you rise up, like I think about people who I've been in Nashville Healthcare Fellows with, or the Aspen. It's like these people are like super achievers. They're like unbelievable. Like all of them like have 3 jobs. One is their real job. One is like some big community role. You know what I mean? Like, but like there's just an effort and a seriousness to achieving, and that includes your health. It does. It includes your health too.
Yeah. Well, and it's of course all related. How you get it, feeling fulfilled about what you do with your day.
Yeah.
Makes you feel better mentally, and that makes you feel like getting out and taking that walk. So those things are all connected, and that's kind of been missing. And there's nothing wrong with social structures. There's nothing wrong with the social structures.
Of course.
That says, weighing 400 pounds is not good. And and the other part of that is, what do we need to do to fix that? And I think that's what Make America Healthy is trying to do.
Yeah.
But we really eroded some basic standards of health over the last, call it 20 years.
Yeah.
Just over 20 years.
Which would be fine if in aggregate those did not cost America.
Correct.
Like if truly there was no impact to the rest of us.
If you're on a mountain in Utah, and you're in poor health, then you're going to deal with the consequences of that, right?
Right. That's right.
But when
That's
you
right.
push those consequences off on other people, and I actually used to be very empathetic, and now I'm getting to the point where you remember that Chrissy Hynde song, "Will you stop all your whining?" I'm like, please, people's whining, just
okay, but I do want to get to what I think is the sticky point on the whole "Make America Healthy Again" bit, right? So I did read I didn't read the full report, but I did read the press release, kind of about the MAHA iteration on CMMI, right? Their Center for Innovation, and kind of the talking points. And Vic and I were discussing how, in a lot of ways, it doesn't look that different from CMMI. It's prevention, it's value-based care, blah blah blah. Except the difference is where the focus is in terms of what needs to change, right?
Yeah.
And Rick Abramson, I think, did a really good job when he was a guest on the show talking about how the three big things that contribute to your health are, genetics, environment, and behavior.
Right.
And maybe, past administrations, and perhaps there's, particular partisan leaning in this, was probably more focused on genetics and environment. And
especially genetics. Yeah.
Yeah. But I think environment as well sort of was in there. Whereas, MAHA is going pretty heavy on behavior.
Yeah.
Right. And so that's sort of the shift. Now, of course, that's fine, but that doesn't quite jive with, the focus on big food, right? Because that's a regulatory problem. That's a regulatory problem, right? That's a regulatory, and a fair number of these things are actually regulatory problems, right? I mean, I would say I don't think this is limited to things like big food and environment. I would say, why the hell haven't we better regulated, Facebook?
Yeah.
Like we all know what Instagram is doing to all of us, but certainly to the kids,
right?
But we don't regulate it, right? Yeah. And then we try to tell. We know that they have hired the best behavioral scientists that they can, to do the same thing to these kids that those Trader Joe's rolls
are doing
to you, right? But and then you want to say responsibility and behavior.
Yeah.
It's like. Yeah, can we maybe get
and as a parent, my oldest is 31, my youngest is 26. Fighting the cultural stream, especially for my youngest,
so hard.
It was really hard. At one point I was going to get T-shirts printed up that said "Mean Mom," on it because, the way in which
you're not supported as a parent.
No, you're not.
You're not supported.
You're a loser parent,
Yes.
So let's look at a little bit more of the MAHA. Scroll down if you would. Okay, so we do have to talk about this because this is very important. Part of the parental health movement has focused on the vaccines.
Yep.
Okay. And COVID was another inflection point.
Yes, of course.
Particularly when we said give pregnant women, COVID vaccines, which is we don't give pregnant women Diet Coke. Okay. There is no basis for it unless you're having to make the drugs, and also for children, we knew they weren't at risk, but we did that anyway. We mandated those things, and what happened? Trust just went through the floor. Okay, and so now you see vaccine exemptions. These are exemptions that are asked that are non-medical or not religious. These are just I'm not going to vaccinate my kid for school. Okay, and you see what does it do? It hockey sticks in 20 and 21. Why? Because of a loss of trust. And the kind of the health policy intelligentsia is really upset about this because they're like, well, this is one of our great tools, which is really true.
Yeah,
especially with take measles. All right, it's a highly infectious disease. So a pregnant woman walks into a room and a child is just developing measles and is transmitting, that would make that child sick, for one. They'd probably recover, but that could kill that baby, in utero. And so there's a public policy reason for that.
Yes.
But mothers around the world are being told to inoculate a 6-month-old against a disease that, the number of 6-year-olds that died of COVID are in the probably single digits, if in fact that's what they didn't have other things. We don't know. But they were like, I don't trust the system. I don't trust anything about you. And so what Robert F. Kennedy and the Secretary of as Secretary of HHS and Marty McCary as head of FDA, they changed the COVID vaccine policy this week.
Yes.
And what they did is they opened the door for okay, if we're going to be approving vaccines, we are going to require a more rigorous standard of evidence. Okay. Now that was a lot of the health policy people are like, oh, no, that's terrible. No, that's not terrible. What they're trying to do, and they said this explicitly, we are trying to reestablish trust.
Yeah.
So we can either sit here and do nothing and trust continues or we can do something.
Look, I think that's fair and that's good. You know, you have to also acknowledge that all of the things you said are correct. I know people, you know, who I think are smart people who came to those same conclusions. But I think you also have to acknowledge we now live in a very, very, very different information age, right? Like the on high does not control the flow of information anymore. It simply does not.
No.
And so you have to think about trust in a different way because I don't care what side you're coming from, like you can have the absolute most truth in the world. And there's a fairly robust group of like flat earthers out there right now that like they've got a megaphone, they've got YouTube channels, they've got whatever, you know, and
your job as a public official, and speaking from somebody who was in office for 9 years, your job as a public official is this really fine mix of I am going to lead you.
Yeah.
But sometimes I have to talk you into it.
Mm-hmm.
You know, in other words, sometimes I have to make my case.
I get that.
And just because I'm here at the front of the room, you know, or Secretary of HHS, you know, at the podium or whatever, no longer means you trust me. And so I have to tell you why you should.
Right.
And they're starting with, in this, to rebuild this trust, they're starting with a flashpoint, which is the COVID.
And it is a flashpoint. And it is a flashpoint.
Yeah.
It is a flashpoint.
So,
okay. All right.
All right. So keep going. And then let's go on to one big, beautiful bill.
All right.
Which is the name that the president gave to it, as a way of trying to convince the House Speaker of the House.
Oh, okay. Well, I just want to make sure we close out the whole Maha thing.
Oh, yeah. Mm-hmm.
So I know about the COVID vaccine. I get that. I understand this treatise that was rolled out last week. This sort of, you know, this is what is it? The manifesto, effectively,
it's a commission report technically.
Okay, but like
I'd call it the roadmap.
The roadmap. Okay, so what is practical in there? Because I'm trying to sort of understand the impact to the industry right now.
Okay.
But and I want to do this before we get to the bill because the bill is so focused on the impact of the industry, right? Through budget, you know, allocations. So I want to understand what in there when you say people are going to be healthy. To me, that circles back to the beginning of the conversation when we were talking about supply demand, right?
Okay.
If people are going to be healthy, you are assuming we are oversupplied today for the world we want to be in. We're oversupplied. We
should be oversupplied on both demographics and on the world we want to live in today.
Both
parts of that.
Okay. So and I want to steer clear of the budget stuff.
Okay.
But what indications do we have are coming from HHS from a Maha perspective that are expected to decrease supply in the short to midterm? Some these big changes they're talking about, those will take.
They're generational.
Those are generational, right? So that's not really that impactful today.
I would say the first thing, the first and obvious is the biotech and biopharma. Okay. And you're seeing this complete meltdown of the biotech industry, which is overfunded, probably over-earned, crowded into the same trades, as we say, the same ideas.
I'm not challenging. I want to qualify when you say things like overfunded, right? It's not a space I invest in.
Right.
And the reason why I don't invest is because of the capital intensity, and quite frankly, I'm just not connected to the kind of capital partners that will take something all the way through the pipeline. So it's just not viable for me.
Right.
Okay. What I observe about it is that even if you get the science all the way through, and the science is remarkable, Where things often get tricky is the economics of it.
Yes.
It's
especially if you're talking about like gene editing and some of this really important stuff.
Yes. There's a combination of immature delivery mechanisms out there today. Our manufacturer's not quite there. Our cold chain is not quite there. You know, there's more things we'd have to build out there. But also, there's just an economics challenge of how you take this asset that works perfectly and then make it into something that's sustainably going to make money for all the counterparts.
So let's cut the biotech industry in half.
Okay.
All right. And let's talk about the problem area. And when I say overfunded, I'm really talking about that part of it.
Yeah. Okay? I'm glad. I wanted to double click and I want to get into what you mean there.
And this part of the industry, it's been a case of get some research that's funded by NIH at Broad or at UC Irving or Johns Hopkins, whatever.
Sure.
All right. That particular project then gets spun out through the commercialization program at those different universities. Okay. And then that commercialized product, whatever it's at this point, you know, it's not there's no revenue, right? There's not, in a lot of cases, even a trial that you can point to. That there's so much pressure to get the original funding out of NIH that a lot of those commercializations projects are a lot of Me Too stuff, a lot of stuff where the science is great. Alzheimer's is the poster child for that. The drugs. And the system is corrupt is too strong a word. Everybody's responding to the incentives that they're given. Okay. But those incentives are bad. And so you have a lot of biotech companies that just never got anywhere because science wasn't great, but there was lots of VC money to throw at it. And the ones that were viable were getting bought by Biopharma to make it all the way to the commercialization. And that process is nearing its end. Okay. Then you have in biotech this stuff that isn't even really biopharma when I think about it, like gene editing. Okay. You know, so we just had a big headline, a baby.
The baby. Yep.
All right. That is a process. Okay. That is scientists in a hospital.
Yes.
That's not really a drug in a bottle.
No, definitely not. Definitely not.
So we're coming to the end of the drug in the bottle, the drug in the vial, you know, kind of thing, unless it has a strong history of evidence. And that's the new policy at the FDA. So a lot of Me Too drugs, a lot of drugs that don't work, a lot of drugs that increase your overall survival, and I'm being hyperbolic here, of course, but increase your overall survival 2 months and you throw up the whole time. I mean, these things happen.
Yeah, okay? Sure.
That's the kind of stuff that you're going to see start to fade away. I think biopharma is in really deep doo-doo, to put it technically.
Well, I mean, I think it was challenged. I think it's been challenged since 2021. Really?
So yeah, because
since 2021,
you have all this loss of exclusivity, which you've known about for years.
Yeah.
And so Pfizer in particular, but also, you know, Merck had this idea, Santa Fe had this idea. All right, all this money coming into COVID, we'll use that vaccine as a bridge to something else. Right. All right. Problem is there is no something else.
There's no something else.
Ozempic became another bridge. Okay. And everybody had to have an anti-obesity medicine. Meanwhile, we still don't have a good therapeutic for Alzheimer's. Aduhelm, you know, and it's I can't remember the other drug. These aren't great drugs, you know, and they have a lot of clinical problems, and you need a lot of supervision and so forth. Parkinson's, you know, you know, childhood orphanage. There's all these things that are happening, and we're shooting people up with Ozempic. Okay, so the first thing is definitely the pharmaceutical industry, which will. I think it's inevitable. It's going to have to get smaller. It's going to have to restructure, and it's going to have to redirect its attention.
Yeah, I mean, you can see it. You can see it happening.
There's a lot of denial.
No, well, I mean, you know, Vic does a good job of grabbing stories every week. So I mean, the stories kind of bear it out. Like Lilly's a world beater, and then past them, it gets
I mean.
Past them, it gets a little, you know, it gets a little shaky.
Yeah. And even Johnson & Johnson. Their blockbuster drug is going to be for something called smoldering melanoma.
I mean, the good thing about Johnson & Johnson is they're like
they do other stuff.
Yeah. They've got they got enough diversity.
They are the healthcare industry.
Correct. They got enough diversity that it's like not that big a deal for them. I would put them out. I'd put Lilly. Roche appears to sort of be in a.
Regeneron is an interesting.
Regeneron's really cool.
Yeah, it's very.
Regeneron's really cool.
Yeah.
I mean, there's a short list of names we could say like, okay, these are ones who are doing like really cool stuff. Right. But like, there's a bunch where you read the stories every week and you're like, oh man, they're like grasping at straws and really, what I mean?
You can just hear them.
Yeah, no. Like there's a lot of challenges out there.
Yeah. So that's the first part of the industry that's going to be affected by making America healthy again. Okay. Then I think my next target is going to be the mental health industry.
Interesting.
And although the mental health industry, we had a real big push, we destigmatized it back to the social, aspects, culture aspect. We destigmatized it. Mental health was something that people need to take care of, which they do. But since particularly
what parts of it is it SSRIs?
So it's the drugs, SSRIs, the ADHD drugs, the antipsychotics. These do not have great records, and they also may have impact, and I say may because the research is not great, on the development of the prefrontal cortex. They may have.
Okay, so I think we're talking not just mental health, but like pediatric mental health.
We are specifically talking about pediatric mental health.
Okay.
Then we have Abigail Schreier wrote a book called Bad Therapy, which is all about are we letting the difficulties of childhood and teenage.
Again, pediatric mental health. I got it. I got it.
Can we work through that better? And then add in Instagram, right? And you got yourself a mess.
I got it.
So if you pull that part, so I think the youth mental health piece of it.
Youth mental health. Okay.
And I think that's going to inform the adult mental health. The research going on about how the gut biome relates to mental health. Yeah. Still early.
Yeah.
But that could be a complete different approach.
I mean, we need to have a different mindset on diagnostics. Mm-hmm. You know what I mean? Yeah. And let people test their damn bodies and get a better understanding of their unique,
right.
Composition and what they should be eating, what they shouldn't eat. Right now, that's so like shameful to be like someone who wants to get tests on yourself. Right. And it's not supported by the healthcare system.
Yeah. Can I write you a script?
It's not part of the preventative model, right? To like get enough diagnostics so that you can learn yourself, so that you can actually take care of yourself.
Right.
So that to me is more fundamental than like actually addressing overuse of drugs and things like that, and overuse of therapy. But. Sure.
Yeah,
sure.
And then the next piece of it, my next is agriculture. That's probably a near term.
Okay, thank God.
Change.
That's a good one. Yeah. I think most of us are happy about that.
Yeah, I don't think anybody's going to be too happy about that. And then in terms of services, there's going to have to be some share taking. It's going to have to run more efficiently, but that's probably out a good 4 or 5 years. Although we're already seeing those changes, but that's where it is. Yeah. And I think something that is actually really exciting, and now that we've gotten past the AI is bad in healthcare, the idea of wearables and that sharing responsibility for your health, that is something that has the possibility to fit very nicely into a Make America Healthy again.
Totally agree.
Especially as those things advance.
Totally agree. Totally agree with that. Yep, that's a good thing.
And then the data that you gather and the information that you gather, and you get to a place where you're. And any doctor will tell you this: the healthiest people are the people that engage in their own health.
100%.
And
100%.
and that's the piece of it that I think will come in the near term as well. So
okay, that was solid. All right, Big Beautiful Bill. Let's go.
One Big Beautiful Bill. All right. So One Big Beautiful Bill is pending at the Senate right now, and the One Big Beautiful Bill is passed the House with a lot of criticism. It didn't cut the deficit enough. Now, let me just make sure everybody understands that deficit number comes from the Congressional Budget Office, which has a record going back since the founding, actually, the Congressional Budget Office, of getting it wrong.
Yeah.
And particularly when it comes to raising and lowering taxes.
Yeah.
Why? Because it's an immensely dynamic system.
Yeah.
And
they do the best they can.
They do the best they can, and they're always wrong.
Yeah, they do the best they can. Yeah.
Now, if you're talking about fairly simple stuff, not so bad.
Yeah.
So it was criticized on the House side for not cutting the deficit enough. The deficit defined by the CBO.
I don't care that much about what it was criticized on the House side. I mean, the House is kind of a. But
the important part is the Senate.
That I care more about this.
Okay,
I care more about the Senate.
The Senate's got the bill.
Yeah.
And they're actually saying, maybe we should have cut the deficit more. And we're hearing,
okay, so the Senate is saying that.
The members of the Senate are saying that.
Like what are the numbers that are being talked about? And also, like, can you talk about key players? Like who's sort of being vocal that matters here?
Okay, so the vocals on the Senate side are Mike Lee, Ron Johnson, who else? You've not heard from any moderates. John Cornyn, who's got a primary challenge in Texas. Ron Paul, who is just a curmudgeon about deficits. There's enough there to affect it. And the most important part is the president kind of backed off of that. Okay, just pass that bill to, if you think it needs more deficit reduction, let's see that proposal.
Okay.
And the areas that are most likely to be a target is the the federal matching rate for Medicaid programs in states, particularly for the expansion populations.
Yep.
So that would affect your California, Illinois, New York, but not Texas and Florida.
Right.
Okay. And this slide here, I ran a few scenarios on how many people would come off the rolls.
That's really surprising.
What?
What you just said.
It is?
Well, where they're looking to cut the deficit anyway.
Yeah. Well, the Medicare expansion population is the
Medicaid.
Medicaid, I'm sorry. Medicaid expansion population are people who are between 100 and 138% of the federal poverty level, and many of them are working, but they're all able to work, because they are not in the other categories in Medicaid: blind, disabled, dual eligible, pregnant women, and children.
Yeah, but okay, let's take that profile for a second. So on one hand, they want the work requirements, right? Like, if you want Medicaid and you can't work,
and the work
you must, right?
requirements are in the House bill.
Yeah.
Effective in 2020.
6? Oh, they pulled it back. It was 7, and they pulled it back to 6.
It was 29, and then it became 26.
Oh.
Yeah, the 29 was kind of a joke. It's like, well, the states aren't ready. I'm like, for heaven's sakes, it's not that hard.
I thought it was 27 pulled to 26.
No, it's 29 pulled to 26.
Oh, okay. All right. So work requirements are likely for a large part of those who are part of the Medicaid expansion checked off, but still, because they're 100 to 140, because you talk like those states have, I know it's all relative, but those states have really high cost of living, and
they do, and I think that the pushback on that is, if you look at how much the federal government pays as a share of the total bill for Medicaid in expansion states versus non-expansion states, it's high. It's
what is it?
It's in the 75%.
Okay.
So the whole program, the original program was, we'll pay roughly half.
Okay.
For California is a wealthy state, for example, we'll pay half. The federal government will pay half. You pay the other half. A state like Alabama, the federal government will pay 60%. You'll pay 40%. But what's happened is the way in which the financing systems work, which I won't bore anybody with right now, has created this system where the federal government is now paying roughly 75% of the bill, even in a state in California where it should be half. And that has to do with the expansion population, where there's a 90% match. And it has to do with the way in which California very carefully and strategically makes sure people are classified in a way that is that gets the highest match possible. We're talking about state
incentives.
It's incentives. Okay, we're trying to pull those incentives back. So that's kind of what the where the play is
Okay.
in those the matching dollars from the federal government, and I think that's a the other part of it. The other debate is on covering undocumented individuals.
Mm-hmm.
California made a very big deal about how we're going to cover undocumented people. I thought at the time, how do you do that? They say, well, we're using our money because the federal government doesn't allow, to use federal taxpayers for undocumented individual. But when you actually pull the numbers apart, there's no way the federal government's not paying for that. Another piece of it is we're not going to pay for undocumented individuals.
Yeah,
and,
I don't expect that to happen.
Yeah, I don't either. And that, if you go to this slide right here, I charted. See how California, the national Medicaid enrollment is a year-over-year change. Look at that. That's the dark blue line. And then the Medicaid enrollment year-over-year in California. And see how those lines are just very close together all through 2018, 2019, 2020. And then in 2023, when California says, okay, we're going to cover undocumented individuals in the state, look what happens. You get the disenrollment across nationally, and California doesn't behave the same. And California. So my estimate, there's about 2 million people in California, for example, that are probably going to have to come off those rolls. And Gavin Newsom, the governor, has said, we're going to have to reduce that.
I mean, he's already talked about that. Yeah.
So there's a lot of consensus on that. The goal is, I mean, there is a goal and there is a desire to get Medicaid expenditures back to the 2019 level. I think that's going to be hard to do, but that's a goal in the Senate. So that's where a lot of the focus is, and I'd say most of the focus in the One Big Beautiful Bill. And then we do have, let's see. All right, supplemental payments. You had asked me about this.
Yes.
Right? So there's two financing mechanisms that are under scrutiny, and then the House side said, okay, and I'll explain what they are in 1 second. But supplemental payments and state-directed payments, those are whatever is in place now, okay? I can stay there, all right? But we're not going to do any more of those.
Okay, that was what the HFMA article was referring to, which is like there's not this huge fallout, so the for-profits are actually going to be okay. Yeah,
everybody should be okay because it's a kind of a status quo.
Okay,
all right.
Was that lobbying?
What? Oh, I'm sure it was, but it also is practicality, right? When you take that much money out.
No, listen. Yeah, I've been wondering how the hell this was going to work. I mean, I'm like, that's not going to work, right? I mean, that's going to crater the health systems.
Yeah, you're moving an aircraft carrier.
Yeah. No, okay. No, that's why I wanted to talk about this, because like we've been, week over week, we're talking about the supplemental payments, state-directed payments, and it's like, guys, I understand you want to kind of correct this potential loophole, but it's now core
now
to operating,
and
it's core to operating.
Let me just stop and explain what the two are and the difference.
Yeah.
Supplemental payments are created when a provider agrees with the state in which it operates in that it will pay more provider taxes. That's typically a bed tax. Okay, they'll pay more taxes, and what happens is that money is paid by the provider to the state. Then the state uses that money to match federal dollars. Then that money comes back to the state. So $1 becomes $2.
Right.
Okay. And it's redirected back to the providers. It cannot be done on a quid pro quo basis. Okay. You just because an HCA hospital in Houston paid, $1 million doesn't mean they get $2 million back. That's the one of the rules. Okay.
Right.
But nonetheless, as you can see from this chart, who benefits from supplemental payments? Primarily inpatient hospitals. Okay, it's always been very bipartisan that the Chris Jennings, who worked for the Clinton administration, he said it's a national scandal how we pay for Medicaid, because it is so opaque. But that's how supplemental payments work. Now, state-directed payments are a little bit different, and mostly what those are, and there's some differences, but mostly what those are is a Medicaid managed care organization. All right, because there's fee-for-service. Supplemental payments exist largely in fee-for-service, but if you're a Medicaid managed care program, how do you get that supplemental payment thing to happen?
Yep.
All right, so they came up with state-directed payments. And what happens there is, in most cases, the Medicare managed care organization agrees to pay more taxes. That makes it same round trip. More taxes go to the state treasury matches those come back, and then the state tells the managed care organization, all right, send that money to those hospitals, that money to those nursing homes, and so forth. Okay.
Right.
And it is again a very opaque process. And in the case of supplemental payments, inpatient hospitals are most likely affected. And if you go to this next slide, this is the state use of state-directed payments. All right. On the one case, most of the money is used for uniform rate increases, and that's raising the rate for everybody in the state who provides services to Medicaid patients. And then there's a few other things, like if you have a value-based purchasing program, it will reimburse you for that.
Okay, so we got 11% going to VBP.
Yeah. Exactly. And this has been criticized because of some redistributive effects and a few other things which are very technical in nature. But this is the other area that has been a focus. Paragon Institute, which is a pretty conservative group that has got lots of former Trump officials in it, has been calling this money laundering or legal money laundering.
I've been reading their emails.
Yeah,
talking about it.
Trying to kind of cast it in this, with some criminality, which is not true.
No,
okay?
it's not great language.
Is it fair for the taxpayers? No,
but they're a think tank. I mean, they get a little license.
But what they're doing is it's not necessarily illegal or anything else. What they're doing is they're making the political system defend behaviors that are not. They're opaque, and like I said, it's a bipartisan.
Right.
Used to be bipartisan. That you should do this a little differently. So the HFMA article, you were noting that they were not, that in these cases, the law is going to change on a go-forward basis.
Right.
All right.
Right.
Now, one thing to keep in mind is that most of these supplemental payments, these extra add-ons for Medicaid payments, those are part of Section 1115 waivers that Medicaid, CMS,
which are basically gone.
So as the state comes in and says, okay, we have to renew our waiver, well, the bar for renewing a waiver is very high now. Very high now.
It's very high now. Yeah.
So we'll have to come up with
so that's what's going to happen. It's like we're going to leave it in place, but you do have a checkpoint, and we just are going to parse it out year over year based on your waivers.
And we're guarding the checkpoint.
Yeah. Based on your waiver expiration dates.
Yes.
Right. Now they're not all annual, are they?
No, they're every 5 years.
Yeah. So they'll stagger over the course of the next 5 years, their expirations.
Right.
And so there will be sort of a takedown of them.
It's an off-ramp.
It's an off-ramp.
Right.
It's an off-ramp.
Right.
Okay.
Yeah,
that's a clever way to sort of not do it right away.
Because you don't want to.
Yeah.
You're going to do a lot of damage.
No, but you're doing it over 5 years.
You're doing it over 5 years, roughly. It could be longer.
That's clever.
Yeah, it is.
Yeah, I mean,
and this, by the way, is how it used to work. Okay, because these two things have never been considered good policy.
Yeah,
and they are only happening because the Biden administration had an attitude of let's just it wide open, take as much money as you want. That was, and you could see it in every single chart I've got. I don't know what the reasons for that were, but you can see it in every single chart. And so what you have to do now is, okay, guys, we've got to get off that high wire and get down to some more appropriate reimbursement. And that's
okay. I mean, Biden administration came along during COVID. Hospitals were screwy then. I mean, so
that was some of it.
It was at least some of it.
2024 is a big year.
Election year.
Yes, exactly.
Election year.
Yeah.
Jobs. Boosting the economy.
Okay, those are good reasons.
Yeah, they're political reasons, but they, I mean, a lot of the things that Biden was doing that year were kind of economy boosting, GDP numbers, kind of like everything is looking really good, right?
Yeah. And that's the economy's big problem is it is very much levered to healthcare and government workers.
Yeah. Yeah.
And you have to, Scott Bessent says, the Secretary of Treasury, we've got to privatize that system. And this is how you would do it. Will the Senate be more aggressive than the House? We'll see. I mean, there's some things they could do. And to make these supplemental payments and the state-directed payments burn off faster. I don't think they're going to do that.
I don't think they're going to do that.
I think they're focused on the FMAP.
Yeah, I don't know why that would
Yeah, I don't.
Be a focus.
Yeah, I don't think. And when you go back to the demographics, this is a problem that's going to have to take care of itself anyway.
Yeah.
You're not going to have the Medicare populations.
It's a much clearer thing, and also politically probably positive for them, because it does have a disproportionate impact on blue states. Right.
Yeah.
Right. I mean, you can mostly divide the map of Medicaid expansion blue and red, right?
Mostly.
Mostly.
Yeah, but you have 9 states that have not expanded. You have Virginia, expanded, and so it's not as clear cut as it was.
It's not that clean
in 2014. Yeah. Why? Because if you can expand and get the government to pick up 77%, well, why wouldn't you do that? And the answer is you wouldn't do that because it's going to cost you further on down the road, which some governors have made that point, certainly in Tennessee and Texas.
Yeah.
So
I think you're right. I think the FMAP is a much safer place for Senate to focus politically.
Yeah, right. Yeah, and the work requirements, they'll pick those up, and how much work requirements actually affect enrollment is a really open question.
How are they going to?
It used to be
test that.
Okay, it used to be really hard, but with the disenrollment, a lot of processes were put in place, and a lot of, for example, if the computer systems can confirm that you are enrolled in SNAP benefits, okay, done. You're qualified. Okay. If it can read your tax return, okay, and it could see and verify your income, done. Okay. If you are in the W-2 1099 system, it can see you. All right. If you are working outside of the 1099 W-2 system and you're in the cash economy, which back to undocumented individual, it's a little tougher. So it kills two birds with one stone.
Well, I just viewed, not entirely, but I certainly could, because I think it's got dual ideological ties. One is to the importance of individual responsibility,
right,
and the second is to undocumented.
Yeah. Well, and if you go back to the birth of healthcare in America, so Lyndon Johnson is responsible for the Medicaid program. Yeah. Nobody ever would have thought about providing health insurance to people who don't work. The state's there to help. Yeah. The very poor, the very sick, blind, disabled. There was nothing. There's nothing in the debate at that time in the 60s where
for the able-bodied unemployed.
For an able-bodied, it was like, because at the time, people had insurance through their employers. The problem that exists is so many people are self-employed, and the individual market.
But also back then, it was probably less of the default idea that you're sick. Like, it was probably less of an individual hazard to not have coverage, right? I mean, because food was better, the environment was safer. Like, it was like kind of other things.
Yeah, exactly. And when in 1965, there was in the 70s, for example, breast cancer was destigmatized. All right, there was this point in time where people didn't talk about women having breast cancer because they were sick. You didn't talk about. Look at Franklin Roosevelt, right? There's like one picture of the guy in a wheelchair. Right. Okay. Right. Because you don't want to project.
Stigma.
You didn't want
weakness.
The weakness.
Yeah.
And so
compare that to Greg Abbott, right?
Yeah, compare that to Greg Abbott, exactly. Right. So you had this change, this cultural shift, and that's back to make America healthy again. That's kind of what they're trying to do, and the work requirements fit fairly nicely into that. Okay. And I think what you're going to see is people who are in the cash economy. Will come out of Medicaid if they can't find a way into the W-2 1099, system.
Okay. Have we covered the big beautiful bill from the healthcare perspective? Like, have we really kind of run down the big issues?
Yes, I think so, because what it's trying to do is save the direction, if you will, was cut $800 million. Yes. I'm sorry, $800 billion.
And but over how many years?
Over 10 years.
10 years, right?
Okay. And the assignment was to the Energy and Commerce Committee. The Energy and Commerce Committee has authority over the Medicaid program. Okay. So basically what those instructions were saying is cut $800 billion out of Medicaid.
Sure.
So there really isn't a lot of other stuff. I will say the SNAP benefits, Supplemental Nutrition Assistance Program, that will be eliminating junk food. Particularly
sodas.
Yep. And the beverage industry is running what has to be one of the lamest campaigns I've ever seen. Which is,
I mean, they're not going to win that one.
No,
they're not going to win that one.
Like, you shouldn't be eating that crap anyway.
You're not going to. I mean, it's called supplemental nutrition. Like it's just. You're not going to win that one. You're not going to win that one.
Well, their campaign is your cart, your choice, and I'm like, that is a loser.
That's dead on arrival, buddy.
Loser.
That is dead on arrival. Okay, all right. So the final one was deregulation.
Deregulation,
which I understand the context of it. So are there any charts for deregulation?
There's really no charts.
Yeah, because it's not well formed yet, right?
It's not really well formed, but I'll point out a couple of things. Okay.
And of course, I just want to make the point. Of course, we're not talking about deregulation of things like agriculture.
No,
because we need more there.
Yeah, we need to see more information. But what we know about healthcare right now is the deregulation is for the first part of it is we are going to eliminate quality metrics that we don't think are valuable. And the first thing, for example, COVID vaccines. If you are a healthcare provider, you get scored on the number of people who are up to date on their COVID vaccine. This is an easy one to do because it's implicates the ability of the workforce. People left the workforce because of it. So we're going to take that out of your quality metrics right now because we know how people feel about it.
Yeah. And also COVID's not a problem. So I think that's kind of a nice, benign, easy one to remove.
There are also things like eliminating metrics on health equity. Okay.
Well, we know that's coming.
Yeah, you knew that was coming.
We know that's coming.
We also know that they've eliminated quality metrics on social determinants of health.
Yep,
and
we know
that's
we know that's coming as well.
But what we don't know is they've asked for more information. The CMS has said, "All right, give us some other ideas. What's hurting your ability to be efficient and successful and to treat patients the way we want?" We don't know what those things are going to be. And if you just look at the history, so this first set of rules that were issued asking for some deregulation ideas, those were mostly written in the Biden administration. All right. And then they're released this spring. So they're all formed up. Then they added their little sprinkle. Okay. The next set of rules, which will be possibly this summer, all right, for calendar year 2026. Or we wait until the spring and summer of 2026 to see what they want to do. Those are going to dive even deeper into the regulatory changes. So that's when you're going to see really where.
Are they going to go beyond quality stuff? Like, are we going to get into?
I think it's going to go well beyond quality stuff. I think it's going to anything that is.
We're not directionally talking about safety deregulation, right?
No, and which is largely a state survey question. Although the CMS has some role. No, it's going to be. I think the first things on the agenda are reporting that doesn't produce results, because what happens is the system is incremental. Somebody comes up with this great idea. We want this piece of information, and it lasts for a few decades. Yeah. So those are the kinds of things that.
So process and reporting, everything's going to be looked at from a perspective of. Well, that's a much larger trend happening right now. Across all industries. Right?
Well, the Trump administration's attitude was in the first Trump administration and this one too is. You all are qualified professionals. They'd operate hospitals and nursing homes and so forth. We expect you to operate like qualified professionals. So we're not going to get all up in your business.
Yeah, and I mean, you're really talking about bureaucracy, right? Like, creating people that need to check the reports because the report exists. Like, not because it actually makes the industry any better.
Right.
And every industry that's highly regulated and has to be highly available because of whatever critical things has this stuff.
And nobody does it like healthcare.
It's nobody does like healthcare. Yep. Okay. So that's one big thing. The thing I was looking for you to talk about that was just starting to make progress in Trump 1 and then COVID hit is competition. That's where I thought you might be going, but you're not. You're not talking about competition.
So what I did not see in this spring set of rules, maybe I see it this summer. Is things like eliminating the outpatient only list. I mean, the inpatient only list.
Right.
That's a list of services that Medicare says you got to do these inpatient.
Yep.
And by the way, it was only created in 2000. It's not even that old,
Oh, that's interesting.
It's protectionism. Right.
Of course. Of course.
The other part of that is the ambulatory surgery centers. There's a list of covered procedures that you could perform in ambulatory. I expect those to go away. And I don't think they're going to be as nice as they were in the Trump one, where they said, okay, we'll phase this in over a period of time. I think they're just going to pull the ripcord. Okay. And y'all knew it was coming. I mean, we talked about it. It got reversed by the Biden administration. So if you didn't figure this out, well, you probably shouldn't be running a hospital. So that I expect that. Price transparency, we're going to continue to see that ramp. The compliance is difficult. The private market solutions haven't really emerged. And it's difficult. Because a lot of these hospitals, they don't even know, it's like somebody checks a box and it goes to billing and somebody hand codes it. And, it's a bit of a mess, but I expect more guidance on that as well.
So in the cycle of government and policy making, when could we expect those types of things to happen? Like, can they happen this year based on agendas and schedules and roadmaps, or are those things? Is deregulation really going to be a 2026 concern?
I'm going to group it into 2026.
Okay.
More likely.
Okay.
And for two reasons. The first is just the rhythm of the system.
Yeah.
The second is the Make America Healthy Again. That policy needed to be published, which it has, and now everybody needs to follow through with that in rulemaking. And what is happening, I'm sure, at HHS is Robert F. Kennedy says, okay, here's the framework. All right, let's make sure that all the rules that we publish conform with those things. And if they don't conform, then we need to talk about how we're going to change the policy. That's what I'm expecting.
Okay.
And if you look at Trump 1, which got started late in the whole healthcare system, but if you look at Trump 1, they really hit their stride late 2018 and early 2019. And I would expect that to happen sooner because we are prepared, or they are prepared. So 2026. Maybe 2025 on some things, but the system is kind of points to 2026.
Okay. I think we ran through.
I think that's it.
Awesome. Okay, I feel clear now.
Okay, good.
I'm good. I think I understand where we are on the bill. Okay, so deadlines for getting the bill done.
So I expect that the one big beautiful bill is supposed to, the talk right now is that it will pass after the June recess.
Okay.
So that's, I think, the first 2 weeks of June.
Is recess.
So before July 4th.
Okay.
Is seems like a
okay.
hard date. And if July 4th doesn't happen, it'll be before the August recess. So,
okay.
So you should see something happen here this summer.
Okay. And then the rollout of the implications from that bill, for states, for federal matching. When does that
So the work requirement in the statute from the House, or the bill from the House, says that the work requirement rules, the guidance from CMS, needs to be done by the end of this year. All right, so you'll be able to see that, fairly quickly.
Okay.
We'll have to see what they do on the FMAP and some other things. But
okay. And how do you anticipate that broadly impacting managed care organizations?
The work requirement piece of it.
Mm-hmm.
I expect you're going to see in California. My estimate is you lose about 2 million people who shouldn't be on the rolls because they are undocumented, which means we can't match a W-2 or 1099. They're in the cash economy. Is where it is. And I'd say nationwide, it's probably about 4 million people would come off the rolls. There are, last I looked, about 72 million people enrolled, not counting CHIP. So it's not a huge difference. But if FMAP changes,
it's 5%.
It is 5%.
That's you know,
it's not nothing.
It's not nothing.
But
that's not nothing.
And for a managed care organization like Centene, which is heavily leveraged to California, it could be impactful.
Yeah.
And then if the FMAP changes, we could see even more, people come off the rolls as well.
Okay.
The estimates, my estimates range, fairly broadly. The one that most of the health policy people are saying is it's 20 million people will lose their insurance, which is not the right way to phrase it, because if you're in Medicaid, all right, and you are kicked off of Medicaid, you have several options. One of those is your employer. A lot of people who are employed and have available to them employer-sponsored insurance, but they enroll in Medicaid. Why? Because it's free, and because they meet the income requirement.
They meet the requirements.
And so the other part of it, of course, is of the ACA offers insurance as well.
Yeah.
But
those will eat into their households. And they're already
if you're in that
thin.
Low income, all right, you're probably going to get heavily subsidized. So it should,
but not 100% subsidized. I guess it's just my point.
It's very close to 100%. In when you're at that low income levels, assuming you're documenting it, and telling the truth, those are very few, very big subsidies. Very big subsidies.
From who?
It's the tax credits.
Yeah.
So you get these
tax credits.
From the federal government.
Okay.
And there are all kinds of crazy incentives in there too. So, but people can move in that. And we've got the fraud people at the GA, the Government Accountability Office, and also at the Office of the Inspector General. Say there's probably 1 million people who are enrolled in ACA and Medicaid. Why did that happen? Who knows? There are lots of people who enrolled in several states in Medicaid. There's all kinds of lack of structure there.
Sure.
That when you just go, 20 million people are going to lose insurance and they're going to be uninsured, that fails to account for, number one, the craziness of the system.
Yeah, it's complicated.
And
I
also
understand that.
It fails to acknowledge the options that 30 years ago weren't there.
And
now are.
No, it's fair. It's fair. I just assume we won't know, and I don't think it's anything to sort of get too riled up about until it all takes place, and then you see how it all washes out. But I was more wondering what the actual sort of impact to managed care broadly is, and you think it's going to be it's not going to be broad. It's going to be, because healthcare is market to market. It's going to be focused in the areas where there's going to be significant disenrollment, which is going to be the areas where
big blue
states. Yeah.
That's where you're going to see most of the impact.
Yeah. Which is even in those states likely to be over-indexed to a few companies.
Yes.
Right.
Yes.
Right. To a few companies that sort of specialize in that population.
Yes.
Right.
That's right.
Yeah. Okay. All right. That makes sense. What about providers? Same. Also geographically.
I'm not super worried about the providers, and for this reason is that, when you're talking about the expansion population, just for example, because the undocumented population, they're working in the cash economy. All right. And let's say they come off of Medicaid, they lose their coverage, for that, just using this one example. That's a population where the insurance is, where their healthcare needs are episodic. And often not particularly severe. Okay, a coverage for a pregnant woman, that's something that the states are going to have to deal with that. But if you're talking about an able-bodied individual, who's working in the cash economy, who gets kicked off of Medicaid program, chances are that their healthcare needs are not that great. And so there is when we say 20 million people are going to lose health insurance, or 4 million or whatever, there's things about that number we don't know. Is the average age 35? Well, you probably don't have much to worry about. Is the average, is it all pregnant women? Well, that's a different story. And so we have to think about that.
What about increased usage of incentives? What about increased usage of ERs as sort of
it's probably urgent
negative
care, just actually centers, but could be
ERs. I think for that population though are a little bit more.
Yeah, we could see more ER use. We could see more uncompensated care.
That's what I'm talking about. That's what I'm talking about.
I just am hesitant to put big numbers on it because
I don't think you can put any numbers on it until it all plays out. Right? I just don't think that makes a lot of sense. It's too complicated. We got to see how are the states going to respond. There's a lot to sort of wash out. Here
we don't know. I just think taking that 20 million people are going to lose in insurance, and 10 million of them are going to die, or whatever the kind of doom and gloom comes out of the health policy. First of all, people do everything they can not to die, and so losing health insurance is probably really far down the list of preventive things that they're doing.
Yeah.
So we just need to see how the system responds. I'm just not that negative on it.
Okay. Thank you.
You're welcome. Thanks for having me.
Yeah, no, super helpful. And we'll bring you back next quarter.
All right, great.